we remove the stitches because we need to insert the bridge work. And this is control OPG 5 days post-operatively. You see how good was the solution with this bone defect and engagement of TPG implant in the area of the floor of the nose. This is the control OPG 1 year after surgery. Everything with all implants is okay. So the patient wanted a very nice aesthetic. We took one more impression. This is metal framework try-in for permanent metal ceramic. Permanent metal ceramic bridge ready for fixation, and fixation of this bridge in the oral cavity. Another case, aggressive maxillary periodontium lesion. You see how bad is the state of the teeth and the state of the bone. So our plan in this case was 2 TPG implants distally to the sinus, 2 TPG implants mesially to the sinus, and 4 KOS implants in anterior area in the floor of the nose. So we started with teeth removal. We inserted TPG implant on the right and KOS implant in frontal area. We did the same on the left. In general, we have 8 implants, 4 implants with cementum fixation and 4 implants with screwing fixation. Open tray impression. This is post-operative OPG, and you see that all 6 implants in frontal area are inserted bicortically. And in 6 days, the lady got metal acrylic bridge work with combined fixation, screwing and cementum. The next case is my personal big pride, because this is a lady, 46 years old, 2 years after osteoblastoclastoma removal. As you see on this 3D imaging, we have a subtotal defect of upper jaw. Alveolar process on the right side is absolutely absent. Frontal and lateral wall of the sinus is absent. Zygomatico-alveolar crest is absent, and part of the zygoma body is also absent. But fortunately to the patient and to us, 3 strategic areas are still present: floor of the nose, tuberopterygoid area, and zygoma body. So we decided to use these strategic areas for placement of implants. Before this, the patient wore a removable denture. The denture was movable because of no bone support. We started the surgery with wide flap elevation to have good visualization of operation field. We inserted 3 implants with screwing fixation into the strategic areas: TPG area, zygoma body, and floor of the nose. We use a lot of APRF for bone substitution. We created a very special design of metal acrylic bridge. You see that all implants are located in different directions, and all implants have screwing fixation of prosthetic device. And this is control OPG immediately after surgery. This is the intraoral state 12 months after surgery. You see that everything is okay. And this is control OPG 3 years after surgery. Intraorally, everything is okay. On OPG, everything is okay. And you will never reach such a result with cementic fixation because all the implants are located in opposite directions. In 2009, in International Journal of Oral and Maxillofacial Implants, the results of multicentric investigations of tuberopterygoid implant insertion were published. I add to these results the results of our colleagues Henry Diederich from Luxembourg and Vitomir Konstantinovic from Serbia. And you can see how big is success rate of tuberopterygoid implants with the follow-up periods of 10 and 12 years. In 2000, Krekmanov described 4 main advantages of distal angulation of the implants in tuberopterygoid area. First, we have cortical anchorage and primary stability of the implants. We can use longer implants because if you will put implant vertically, you will have distance maybe 10 millimeters. If you insert implant obliquely, the length of the implant could be 21, 23, 19, and so on. We provide distal support and distribution of chewing forces along the buttresses, which is very naturally. And finally, we have shortening of inter-implant distance and broadening of prosthetic base. In 2004, in German city of Marburg, the PhD dissertation was performed by Turkish scientist. The use of angulated implants in the maxillary tuberosity, a 3-dimensional finite element analysis. And it was established on the basis of this analysis that the best angulation of the implants in tuberopterygoid area is 45 degrees from the biomechanical point of view. At the end of my speech, I want to show you one of the very important, as for me, publications, which was published in ICOI Implant Dentistry Journal, which was published by American doctors who compared traditional Brånemark implants of different length, 1518 and 713, with and without penetration of pterygoid plates. And the conclusion of this publication was as following: engagement of an implant apex into dense cortical bone is necessary to provide strong initial stability. The medial and lateral cortical plates of pterygoid process allow such stability in posterior maxilla but require the proper implant length. This implies that longer implants fully engaged the cortical plates produce the ideal biomechanical scenario to restore posterior dentition to the patient. Why this publication is so important for us? Because as you see, traditional implantologists only now start thinking about usage of cortical plates, and we, together with you, are doing this for more than 30 years. Regarding complications of placement of TPG implants, we must remember about the factors providing limited access to the tuberopterygoid area. They could be a thick mucosal layer, blade-shaped alveolar process in distal maxilla, excessive sinus pneumatization, and deformed bone type. And regarding a real intra- and postoperative complications, they could be fracture of the tuber maxilla, bleeding as a result of maxillary artery of pterygoid venous plexus damage, or absence of osteointegration. As conclusion, engagement of strong cortical areas of pterygoid process becomes more and more popular in implantation treatment protocols. Tuberopterygoid implants creates a serious alternative for traditional crestal implants with a lot of additional surgical procedures, possess a high success rate up to 99% within 10 years, and give us unlimited solution in rehabilitation of distal maxillary defects. The procedure of tuberopterygoid implants placement require no general anesthesia, keeps sinus integrity, provide functional and aesthetic component of treatment, improving quality of life of our patients. But procedure requires deep knowledge of anatomy of craniomaxillofacial area and must be performed by highly skilled specialists. I would like to finish my speech with the words of famous American implantologist Ivanov, that absolute implant stability is thus an ideal therapeutic principle that is inseparable from cortical anchorage. Thank you for your kind attention.